Welcome to the Physicians Lounge, a podcast of the Mississippi State Medical Association. The Physicians Lounge was created to provide ease of access to information and resources on current topics affecting healthcare. This episode focuses on understanding the Ryan White HIV program. Joining us today are Dr. Paul Byers, Dr. Thomas Dobbs, and Dr. Ben Brock. Dr. Byers is the former state epidemiologist with the Mississippi State Department of Health and currently working at the University of Mississippi Medical Center in Preventive Medicine in the School of Population Health. Dr. Dobbs is the Dean of the John D. Bower School of Population Health at the University of Mississippi Medical Center. Dr. Brock is the Medical Director of the Adult Special Care Clinic and Associate Professor at the University of Mississippi Medical Center, Division of Infectious Disease. Thank you for joining us.
Hi, and welcome to the Physicians Lounge, a podcast from the Mississippi State Medical Association. I'm Dr. Paul Byers, your host, former state epidemiologist, and currently a faculty member at the University of Mississippi Medical Center, Department of Preventive Medicine. Today, I'm joined by Dr. Ben Brock and Dr. Thomas Dobbs, and we're talking about the Ryan White program. Welcome. So, improving the care and well-being of people living with HIV is obviously a shared public health priority. And the Ryan White program funds cities, states, community-based organizations to provide support and access to care and treatment and drugs in some cases. Tell us a little bit about the Ryan White program and some of the programs around it.
I mean, a great place to start is, who is Ryan White, right? I mean,
Agreed.
Yeah.
A little bit of the history.
Yeah, so folks who've been around for a while, like Dr. Byers and me, remember Ryan White. He was a child, I guess like an adolescent, when he acquired HIV through blood products. I think he had hemophilia, and he really sort of captured the heart of the nation about how cruel the HIV virus was, and sort of mobilized a lot of political will to confront HIV head on. And they created the Ryan White program that helps support people living with HIV, provide services and cover insurance and that sort of stuff.
Yeah, Ryan died a few months before his namesake legislation was passed, I believe, actually.
Yeah.
And so that's a little bit of the background, but this is a federally funded program, and what are some of the aspects of the program that it supports for people living with HIV?
You know, there's big sort of buckets of what it funds. One of it's going to be like the Part A program, which is really going to be the big cities, and that's where a lot of the funding has gone, especially early on, where a lot of the morbidity mortality was. There's a Part B program that supports states, and then states can then go on to support other clinics and other partners in providing services, not just HIV care, but a lot of it can be sort of social support services. Having a social worker and counseling and support with pharmacy counseling, that sort of stuff. And then we have Part C, which is going to be for clinics, like Dr. Brock, who runs a Part C clinic.
Yep. And so we get Part C and Part B, and I guess one of the things to know with Part A and B that goes to cities and states, we do not get any Part A in Mississippi, so none of our cities are populous enough to have enough HIV cases to get Part A funding. So New Orleans and Memphis do, but not
Right.
Jackson or any of our other smaller cities. But in drawing down those funds from the state, from Part B, Part B with the state does subcontract out clinics across the state to provide various services. Some of those are not HIV clinics, so some of those are organizations that are conducting HIV screening.
Mm-hmm.
But that actually is a mechanism that smaller HIV practices could leverage, is resources from the Part B program, and being aware of those resources. Part C funds little regions of the state, so you might apply directly to HRSA for a 6-county area that you're going to call your region as an HIV clinic. But you could have a smaller scope submitted to Part B through the health department, and get some funds to help support your clinic if you're a smaller HIV program that has some patients and needs some support. Or the Part B program might be able to directly support some of the work you're doing.
And I think the key thing for Mississippi docs to know about Ryan White is it's a program through which people living with HIV can access care essentially no matter what. If you don't have insurance or if you have high copays, we even have undocumented folks who can get some support, right? So I always want to tell docs, don't worry about the money part. If you get them to a Ryan White clinic, they will make sure that they have the medical care and the medications that they need.
So what are some of the support services that a clinic could access through this? I mean, a clinic can be part of this program by working with the state, but what does it support in their clinic? Is it direct patient care? For a clinic, yes, but most doc clinics are not going to want to get involved, right? I mean, really, they just need to get somebody referred to a clinic that has Ryan White services, and there's a few of those around, and some of them are Part B and some are Part C, but they both can supply the same sort of support. Ben, what are you thinking?
Yeah, it's sort of this catch-22. Higher volume clinics have the resources to be able to provide guidelines-based therapy, consistent therapy across the board. Getting access to patients in more rural areas is a challenge, and so if you have a patient who's counties away from the nearest Ryan White clinic, having a model where they are able to have some specialty support and utilizing their local clinic is something that might be innovative. But yeah, I think the majority of patients would be best served in a Ryan White clinic. One of the biggest issues is the lack of is the availability of case management services at these Ryan White clinics, where they can help the patient navigate this complicated healthcare system, particularly with the cost of the medications and commercial insurance. Copays are real high for these medications, and they have to meet their deductible. And having case management services that can help navigate that issues is probably the biggest resource that the Ryan White clinics have, besides the HIV specialty expertise.
Now, as far as the Ryan White program, providing direct care is an important piece of it, but many times there are other barriers to accessing care that Ryan White can also help, or if it's with dental care, or in some cases with transportation, can it do some of those things as well?
Yeah, I think you really hit on it. I mean, the thing that makes it kind of special, Dr. Brock and I work in the clinic that for which he directs, and we have, like, when I go see a patient, it's really amazing. We have someone doing a substance abuse screen, right? Mm-hmm. And then, I'll go in and see them, and then there's a case manager, a nurse case manager, and then there's a mental health specialist that comes in, and a social worker who's available. We have basically all these things that are, and y'all have done a great job, putting together quite a program that really it's a safety cocoon to make sure that any gaps that persons have, we can help. I mean, you can't solve everything, but whether it's going to be transportation resources, food insecurity, housing insecurity, not that it's always easy, but everything is around to make sure the patient can have a successful therapeutic experience. And I think it speaks to how successful the clinic is in viral suppression rates. And Ben, what is the viral suppression rate now at ASC?
Ooh, it's approaching 94%. That's just a snapshot in time. So, but yeah, it's all because of that, because of the improvements in the medications and just all those resources. Yeah, so those are the allowable use of funds that HRSA, the agency that administers Ryan White, they have a list of things that you can use those funds for that include assistance with medical transportation, social work support, medical case management, substance use treatment. The list goes on. It will not pay for emergency department visits or inpatient hospitalization, so it's just outpatient care. And it will only pay for the care of people with HIV. So that's one of the big gaps.
That's what I was going to ask.
Yeah.
So what about the patient who, as far as doing some screening, it will pay for that? Is that correct?
High risk screening. So
Yes.
it will. There is a carve out to allow for high risk screening. One caveat is that most people who are seeking HIV screening, actually seeking it, especially if it's in the setting of an HIV or STD clinic, would likely qualify as meeting those criteria, because those are subjective. But PrEP services are explicitly not covered by Ryan White, and that's a big funding gap where in the what we call the care cascade, PrEP doesn't have the same sort of program to help address people who are at risk of HIV.
Well, you illustrated some of the obvious benefits, and I think there's data that supports that people who are utilizing care through Ryan White have better viral suppression rates. And you mentioned docs leveraging this program, or healthcare providers in Mississippi. How can they do that? Do they contact the state? Do they work with local Ryan White clinics in their area to set up or establish a referral network?
There's several ways people can get access, right? So I mean, one of the ways that's probably the most direct is if someone is diagnosed newly with HIV, the health department professionals are involved in identifying early counseling, identifying contacts, but also early referral. And so a lot of times the disease investigation specialist is responsible for making that linkage. And so that is one way of doing it, but I mean, there's a lot of ways that people come into the clinic.
Yeah. For people across the state, probably utilizing ADAP is on that list. There are some non-Ryan White providers who send prescriptions to the AIDS Drug Assistance Program pharmacy, and that's a mechanism to help address some of the copay issues. I do know some providers who don't have a Ryan White program in their clinic who have a small number of HIV patients and utilize the ADAP pharmacy. There are there's a limited number of social workers embedded at the health department through the Part B program that can provide some social services, but they're covering large catchment areas, and so that can be a challenge, and they may be dually assigned to cover, the Pike County Health Department, for instance, and they're also doing a little bit of Ryan White.
But like if a doc had somebody they wanted to refer them, the health department's a way to, I guess, make sure you get that linkage.
Right. That's a big thing they're doing is linking. Right.
But I guess like if you wanted to do a referral to UMMC's clinic, that could do that directly, right? They could come in. We've seen some of that, and also other clinics, GA Carmichael, and Samurai, Southeast Mississippi Rural Health Initiative, other big clinics. I know Coastal, Aaron Henry. I think these are other places that are Ryan White funded clinics that sort of have a focused clinical endeavor. Garfield in Tupelo, it's a Ryan White clinic too, isn't it?
Yeah, and there actually is a search engine that's got a geolocator. So if you go to HRSA's website, it's findhivcare.HRSA.gov, and there's a similar one for FQHCs. And if you type in a zip code and ask for a radius of whatever you specify, 100 miles, it'll list all of the Part C recipients. So it's not completely inclusive because there are some clinics that get Part B funds only, and they will not pop up in that search engine.
So has access to care improved with Ryan White funds?
I assume so. I think it's a huge safety net program for people with HIV. Without the Ryan White program in America's healthcare system, a majority of people with HIV would have difficulty accessing care, I would imagine.
And if you think about the subset of the population we serve, I know when I was working in Hattiesburg at Samurai, over half of my patients did not have health insurance. Otherwise, they would not be able to access, they would not be able to pay for medications, they would not be able to get labs. Labs are very expensive, not to mention, engaging in a clinical encounter. So I think it's been huge. I mean, I can't even know that we could imagine what it would be like, because it really has existed before we really had an effective antiretroviral therapy.
Yeah, and it's a safety net program in the way that it helps support salaries of healthcare providers to be able to provide these services, but also enhancing the care for people with HIV with all these wraparound services that are really unique to the Ryan White program. And I really feel like primary care needs to have those resources embedded in them too. It's really, it's such a challenge to practice medicine and not be able to address the social determinants of health, for instance, that we know are so important to patient well-being and chronic disease management.
It would be great to have that across the board.
Yeah, it really would. It'd be fantastic.
So obviously there is really no reason for someone who lacks health insurance to not be able to access care and treatment for HIV.
Yeah, in theory, but every Ryan White program looks differently. So with the allowable use of funds, those funds are still finite, and every program structures, uses their discretion to structure the program that, fits their program's needs. Some of our clinics across the state are smaller and have less funds to provide these services, and so they have to pick and choose what staff they want to have, how many social workers, what sort of things they're going to offer, and so any given program and state Part B programs in different states will look different to meet that state's needs. So,
well, I think this has been a good introduction to the Ryan White program. Any final thoughts?
We didn't touch on ADAP, and that's a huge part of the Part B program with the health department. Just knowing that those funds that go to the state, a big chunk of them in Medicaid non-expansion states like Mississippi, go to pay for the medications.
Yeah,
And
AIDS Drug Assistance Program. That's
the
the
AIDS Drug
acronym,
Assistance
right?
Program.
Yeah.
Right.
Yeah, and so the health department pharmacy dispenses a lot of antiretrovirals in the state and ships them out to patients across the state. So it's a centralized pharmacy program, but that's a huge resource, and a very large chunk of the Part B dollars go to pay for that.
And is that a limited formulary, or is it cover the appropriate medications?
It
It
covers all the antiretrovirals, yeah.
And also a subset of sort of normal chronic medications, high blood pressure, some antipsychotics, mental health meds, cholesterol, diabetes meds, but actually you can go on a search engine and type in Mississippi ADAP formulary. It'll show you everything that they have.
That's great.
Yeah.
Well, thank you both.
Hey,
Thank you.
Yeah, it's great to be here. Thank you, Paul.
Thank you for joining us. Show notes for this and MSMA's other episodes are on podbean.com or on msmaonline.com. Support our show by subscribing and leaving a review. Thanks for listening, and see you next time. Brought to you by MSMA. We are the physicians who care for Mississippi.